Good afternoon, and welcome to today's webinar titled Traumatic Brain Injury in Seniors by Dr. Cynthia Boyer. My name is Laura Jacobs, and I am the Education and Outreach Coordinator for the Brain Injury Alliance of New Jersey. We are a nonprofit organization with a mission to provide education, awareness, and support for those who have been affected by brain injury. Today's presenter, Dr. Cynthia Boyer, is a clinical psychologist with 30 years experience in neurorehabilitation. Her professional career has focused on the neuropsychological evaluation, psychological treatment, and cognitive rehabilitation of individuals with acquired and degenerative brain injuries. Dr. Boyer earned a BA in psychology at the University of Pennsylvania and a master's and PhD in clinical psychology at the University of Delaware. She has provided clinical services in a variety of settings, ranging from the trauma center to long-term post-acute programs. An accomplished clinician, Dr. Boyer also has a strong background in administration, strategic planning, program development, and clinical quality. She served as Executive Director of Brain Injury Services and Vice President of Quality for Bancroft. In addition to her clinical work, Dr. Boyer holds faculty positions at Philadelphia College of Osteopathic Medicine and Widener University and is a trainer for the Academy of Certified Brain Injury Specialists. She serves on the board of the New Jersey Brain Injury Alliance and is a medical rehabilitation surveyor for the Commission on Accreditation of Rehabilitation Facilities. Currently, Dr. Boyer is in private practice in Cherry Hill, New Jersey. She is also a clinical consultant at ReMed, New Jersey. So, with no further ado, Dr. Cynthia Boyer.
Good afternoon, everyone, and thanks for taking some time on this beautiful day to learn about brain injury in seniors. This topic actually combines two areas that I'm really passionate about. As you heard from my biography, I have worked in the brain injury field for a very long time. And over the past probably 5 years or so, I have become more involved with geriatric psychology and working with seniors. So this is a nice opportunity to combine both worlds. So I'm going to start with a little overview. Whoops, I'm sorry. Hang with me till I kind of get the hang of these slides. Now I'm going to take you back too far. Hope I don't make you dizzy. So I'm going to start with a little background on traumatic brain injury so that I don't make any assumptions that folks who are listening know about traumatic brain injury. So traumatic brain injury has often been referred to as a silent epidemic. And I would suggest that as we talk about traumatic brain injury in seniors, it's an even more silent epidemic. And it's kind of curious that it would be silent when you look at the numbers. The latest numbers that we have from the CDC is that there are upwards of 1.7 million traumatic brain injuries every year. 1.4 million people are treated in the emergency room. Many, many people get no treatment. Of the folks who present to the emergency room, about 275,000 are hospitalized, and there are about 52,000 fatalities. So this is not an insignificant problem that we're talking about. It's a large number of people that are affected. And when we talk about the brain, as you all probably know, the brain controls everything that we think, feel, and do. So if you have an injury to your brain, you can have problems in any number of areas since the brain controls everything. So I just want to, again, talk a little briefly about some of the problems that happen with a brain injury. So the physical problems, and the most common physical problem after a brain injury is headache. And headaches are fairly nonspecific, but they can be fairly debilitating if you have them. The other common physical problems are fatigue, and long-lasting fatigue that occurs for many, many years post-injury. Dizziness and sensitivity to light and noise can also happen, and some kind of motor problems. Motor problems can range from being clumsy, not having good balance, to having weakness and paralysis on either one part or both parts of the body. And then another common physical problem following a brain injury is to have some decreases in your senses. Particularly smell is affected following even mild brain injuries. And then in some other individuals, vision and hearing can be affected. Moving along, if you kind of think about cognition and thinking, the areas that can be affected following a brain injury are really vast. So I'm going to go over these so that you have a sense of them and can understand kind of the most common problems. Really, the most common problem following a brain injury is slowed processing. So the individual may be able to complete all the tasks that they completed previously, but it's at a slower rate and a reduced efficiency in terms of their ability to do so. Short-term memory loss is very common, and what we mean by short-term memory is that day-to-day memory. It's not long-term memory, where did you go to kindergarten, who was president during the Civil War, but what did you have for breakfast, what's on your grocery list, those short-term types of things. Other cognitive problems can be difficulty initiating or starting activities. Oftentimes, this can be confused as depression, so that individuals may have some difficulty getting started with things. They may be distracted and have a shorter attention span. Many times they're impulsive and can have poor judgment. Their problem solving is impacted as well, so that there's a decreased flexibility. They can see one way to solve a problem, and it's that way or no way. And then finally, there can be communication issues. In some cases, they may have difficulty coming up with words. In other cases, it may be difficulty coming up with words quickly. And in still other cases, it may be a social type of communication issue. So you can see that these cognitive impairments really range the gamut in terms of day-to-day activities. And then the other area that is very commonly affected following a brain injury is emotional and behavioral types of presentation. I'm going to highlight depression because we're going to talk about that a little bit more later, but depression can be a fairly common side effect or, excuse me, emotional change after a brain injury. Anxiety. We also already mentioned impulsivity and being irritable, having a short fuse. So there's just this kind of overall change that can take place in the individual's personality and behavioral presentation. And I want to note that for these physical, cognitive, and behavioral changes, an individual may have one, they may have two, they may have 10, they may have kind of a few or many of these changes take place. There's kind of a popular saying in the brain injury rehabilitation world, if you've seen one person with a brain injury, you've seen one person with a brain injury. Everybody's brain is different, so the way that they react to a brain injury is going to be different as well. So don't think that because somebody's had a brain injury, all of these things are going to happen. Kind of just know that there's many, many combinations and permutations of these various symptoms. So when we kind of take these all together, it really can result in an individual who has difficulty navigating day-to-day, even with more mild injuries. They may have difficulty learning new information. They may be inconsistent. Sometimes they can do things, sometimes they can't. And then the other challenge that presents itself often following brain injury is that despite the presence of these challenges, the individual with the brain injury doesn't really appreciate or acknowledge those changes. Their loved ones, their support system, their employer may see the changes and be painfully aware of them, but the individual with the brain injury may not be. So when we talk about traumatic brain injury in older adults, the statistics look at 65 and above. Some of the newer statistics actually kind of break out what they call the young old. So the young old, if you're curious about this, is 65 to 80, and the old is 80 and above. And we'll talk a little bit about how there are some changes and differences between the young old and the old, but we don't always have really good statistics. We're just starting to develop some of those. So if you remember earlier, and there's no quiz on this, kind of the annual estimate of emergency room visits for TBI is in the ballpark of 275,000. Of that 275,000, 80,000 of those are for older adults. So you can see that that is a significant proportion of individuals with brain injury who are presenting who are older adults. And even more significant, of those older adults who present to the emergency room, they are significantly more likely to be hospitalized than younger adults. So when an older individual has a brain injury, even a milder brain injury, they're much more likely to have symptoms that are going to require hospitalization. And we'll talk about why that is in just a few minutes. And you can see from the figure there that the cost in terms of monetary cost are staggering, and that doesn't even account for kind of the emotional and psychological cost to the individual and their family for these injuries. So our statistics for traumatic brain injury always lag a little bit. And for many, many years, motor vehicle accidents were the primary cause of brain injury in all adults. So when you kind of group everybody together, motor vehicle crashes were the primary cause. But in recent years, there's been a change so that now the most common cause, the most prevalent cause of brain injury is actually falls. And the reason for that has to do with the aging of our society. So as our society ages and more people are living longer, falls become a greater risk overall for those individuals, and falls are now the leading cause of brain injury. Moving to looking at older adults, you can see that in older adults, more than half of brain injuries are caused by falls. So by far, falls are the biggest risk factor and the biggest cause of falls in the older population. And there are lots of reasons for that. You know, when you think about what happens as somebody ages, they have slower reflexes. They may have some cognitive challenges. They may have some coexisting medical conditions, and we'll talk about that more later as well. And then as individuals age, because of the aging process, their bones are less dense, so they're more likely to have injuries following a fall. Motor vehicle crashes, even though that's a small number relatively speaking, 9%, it's interesting to note that for older adults who are involved in motor vehicle crashes, they are much more likely to have a significant injury and even fatality versus kind of younger individuals who are involved in motor vehicle crashes. And then assaults is a very small number. So we'll be focusing primarily on falls today as a cause of TBI, and talk about kind of why falls happen, what happens in the brain when a fall happens, and what we can do to prevent them. I did also want to talk a little bit about the epidemiology of traumatic brain injuries. In the younger population, males tend to outnumber females when it comes to frequency of TBI. And traditionally, that's been because males tend to take more risks than females and tend to be a little bit more reckless. And I have kind of good news, bad news is that in the younger population, females are catching up. So there's more equality in that kind of risk-taking and involvement in sports and so forth. So there's kind of less of a difference, even though it's still there. When we look at an older adult population, the risk is about equal in the younger old. So at around age 65, whether you're male or whether you're female, you're about at equal risk for having a TBI. As you move into that old group, that over 80 age group, women are more likely to have traumatic brain injury. Couple of reasons for that. Primary one being that if you look at mortality rates for men and women just in general, women tend to live a little bit longer than men. So if you have more women kind of living in that age group, you're going to have more women sustaining brain injuries. And then if you kind of think about some of the risk factors that I just mentioned, women may be at a slightly greater risk for some of those risk factors, particularly the reduced bone density and osteoporosis and so forth. So moving ahead and kind of thinking about statistics, adults over age 65 had the highest rate for TBI-related hospitalization. So when we kind of think about TBI, we tend to kind of think and hear more about kind of younger individuals who have TBI. But in fact, when we look at our hospitalization rates and who is receiving treatment for TBI, it's actually our seniors and older adults. And this is increasing. It's increasing because the number of people who are living longer are increasing. So the percentage of people who are living past age 65, past age 75, past age 85 and 95 is increasing. So that number of people being hospitalized is going to continue to climb. Unfortunately, the bad news is that for individuals over age 65, and as you get older, as you go over age 70, over age 80, the mortality rates following TBI are significantly higher than they are for younger adults. So the mortality rates for older adults are about twice what they are for younger adults. When we look at the frequency of severity of TBI in older adults and younger adults, we know in younger adults the vast majority of traumatic brain injuries fall into what we call the mild range. So about 85 to 90% of TBIs are classified as mild. That same severity range is in existence for older adults as well. So there's not really kind of a difference in distribution of severity. The difference is that the older adult's brain is different. So even a mild injury, don't be fooled by the word mild. Even though we call it a mild injury, the effects can be anything but mild. They can be very significant for the individual. And remember, for our older adult population, they may be coming to us with some pre-existing conditions that already put them at risk for cognitive decline or physical decline. When we look at the brains of older adults, and I have a couple of pictures I'm going to show you in a little bit, one of the things that we know is that older adults have more chronic diseases. The estimates for medical conditions in older adults range from a low, and notice I said low, of 73% of older adults have some sort of pre-existing medical condition to a high of 99%. So the vast majority of older adults have some sort of pre-existing condition: arthritis, diabetes, high blood pressure, high cholesterol, renal disease, many different types of chronic diseases present at very high rates in this group of individuals. There's also, for this group of individuals, for older adults, you're much more likely to see individuals who have either mild cognitive impairment or some sort of dementia. And the estimates there range from a low of about 10% to a high of about 25%. So you can see that in the presence of these pre-existing conditions, there can be some individuals who have both physical and cognitive challenge even before they have a brain injury. So when we look at outcomes for this group of individual, you're going to see much higher rates of mortality, as I already mentioned, but disability and rates of death are going to be higher for the over 55. For these studies, it's over 55 is kind of classified as older individuals, which is a little bit depressing for some of us. So you can see these high rates of injury and very poor outcomes for many individuals. Not all, but for many individuals. So what are the predictors of poor outcome? In younger individuals, we know that age is a factor. So for younger individuals, if you're younger, you tend to do a little bit better if you have a brain injury. So that is the same type of predictor of outcome that's present for older individuals. So for older individuals, the older you are, the less likely you're going to have a good outcome. So if you're 65 and you have a brain injury, you're likely to have a better outcome than if you're 85. Injury severity kind of goes without saying. The more severe that your injury is, the more likely that you're going to have a poor outcome following your brain injury. If you have previous history of brain injury, and this is also true in a younger population. So the first three predictors are predictors for any population, and they hold true for our older individuals. If you have a previous brain injury, your resources, your cognitive reserve is reduced, so likelihood of a good outcome is going to be reduced. Males tend to do a little bit worse than females in terms of injury. There are some protective factors of hormones that even though hormones are diminished in older adult women, they still have some of the protective features. And then the last predictor is kind of interesting. We know that there are some genetic markers that have been identified for some dementias, Alzheimer's in particular. So there is some evidence to suggest that individuals who have a genetic marker for Alzheimer's disease are going to do a little bit worse following a brain injury. So let's talk about falls. I mentioned earlier that falls are the leading cause of brain injury overall, and falls are the leading cause of brain injury in our older adult population. And the numbers are actually pretty staggering. They're the fifth leading cause of death in individuals 65 and above. And it seems like every couple of weeks you see information in the news about a public figure, a famous individual who has sustained a brain injury following their fall, and then succumbs to that injury. So a couple of individuals that you may or may not know had a brain injury because of their fall and eventually died from that are Katharine Graham, the publisher of the Washington Post, who was just featured in a movie, Robert Atkins, the famous diet doctor. So a number of individuals, and certainly it's not just famous individuals who sustain these injuries and pass away from them, but all kinds of people do. So it's a significant issue. Okay, so what are the factors that lead to falls? Normal aging. We talked earlier about the things that happen as a result of normal aging, that cognitive slowing, the slowing of reflexes, some changes in our sensory processes as we get older. Vision may be a little less sharp. Hearing may be a little worse. So just normal aging by itself is a risk factor for fall. Then there are certain medical conditions that make people more likely to have a fall. Some cardiac conditions, Some arrhythmias, AFib, can cause dizziness and lightheadedness. We know that diabetes causes peripheral neuropathy, so that loss of feeling can lead to falls. So there are many medical conditions that have risk factors that contribute to falls. And then cognitive impairment, reasoning, judgment, memory, all of those problem solving, all of those cognitive factors influence our ability to motor plan, to use good judgment, and to be safe. So if those are impaired, they may lead to a fall. And then finally, some medication side effects. Many medications can be sedating or can cause dizziness, lightheadedness. So those types of factors can lead to falls as well. I mentioned earlier depression as kind of a sequelae of brain injury. It also, unfortunately, is very common in older adults. It's common in older adults who are community-based, who are living kind of in their own homes, and even more common in older adults who are in assisted living or skilled types of facility. And there is a fair amount of research that shows that even kind of taken by itself, depression can increase fall risk. Many of the symptoms of depression mimic kind of some of the fall risks that we just talked about. So there are cognitive symptoms of depression, decreased speed of processing, kind of decreased motivation. That can lead to a susceptibility to fall. There are also sleep and appetite changes that can take place because of depression, and particularly if the individual has a decrease in these areas where they're eating less and sleeping less, there is kind of a significantly greater risk of fall. And then some of the medications that are used to treat depression can have a sedating effect, so can influence the individual. So in addition to the previous factors that I mentioned, keep in mind that for older adults who have any level of depression, and particularly untreated depression, because the cognitive effects, the mood effects, and the sleep and appetite effects certainly are greater than any of the medication effects. And depression can be treated with both medication and psychotherapy, so it really needs to be assessed and addressed. So when we talk about factors that influence recovery in our older adults, one of the things that we need to keep in mind is that certainly as we age, our whole body changes, and we've talked a little bit about some of the factors that can kind of influence brain injury and lead to a brain injury because of aging. Now we're going to talk a little bit about recovery and kind of how the changes in the brain that happen with the aging process influence both the injury process and the recovery process. So as you can see from these two brain scans, and you don't need to be a physician or a radiologist to kind of see what the differences are. As we age, our brain, even kind of with normal aging, with no dementia at all, our brain tends to shrink a little bit over time. So you can see that very clearly in these comparison slides between a 25-year-old and a 75-year-old, how the brain has shrunk over time. So that means that with the atrophy in the brain, there is kind of more room in between the skull and the brain itself. So in the younger brain, and I'm going to kind of go back here to this slide again, in the younger brain you see, where the dark black is that there's not a whole lot of room between kind of the brain and the skull. But on the right-hand side, if you look at the other scan, particularly particularly in the front of the brain at the top, you see that there's a fair amount of room there between the skull and the brain because of that atrophy. So what happens is, in brain injury, we know that part of the injury takes place because of the moving around of the brain in the skull, and that there are secondary factors that take place after the initial injury. So for older individuals, not only do you have that atrophy that is present, remember I said kind of about the pre-existing medical conditions, you have a lot of older adults who already have some pre-existing cerebrovascular risk factors. So maybe they have peripheral artery disease, or maybe they have high cholesterol or high blood pressure. So we know that the blood flow in the brain is not as free-flowing as it would be for a younger individual who does not have those compromises. So what happens in these injuries, and this kind of is another picture that kind of shows you the difference. The younger brain is on the left and the older brain is on the right. So what happens with these injuries over time is that you see that there is swelling in the brain, and that happens whether you're older or younger. The blood flow is disrupted, but if you've already have cerebrovascular risk factors as an older adult, that is going to mean that your blood flow in the brain is going to be significantly more disrupted than a younger individual. So remember that most of the brain injuries in older adults are caused by falls, and they're caused by what we call low-level or same-level falls. So, you know, the individual is standing and they fall, or they fall getting from the bed to their chair, or from the toilet to their chair, or toilet standing up. We're not talking about somebody falling from 50 feet, from 100 feet, from 200 feet. They're not falling very far, but nevertheless they're falling. And because of the changes in their brain in older individuals, they're more likely to have a hematoma or a contusion. So they're more likely to have some sort of lesion in the brain because of a fall. Whereas in motor vehicle accidents, the primary type of injury is what we call diffuse axonal injury. So it's from that kind of moving back and forth of the brain in the skull. What happens in older adults is you don't have so much the moving of the brain in the skull. You have a little bit of that, but what you have is the skull is impacting something else, and the brain kind of hits the skull. And because of the atrophy of the brain in older individuals, you're more likely to have a hematoma and more likely to have bleeding in the brain. So when you have this bleeding in the brain in younger individuals, because that space in the brain, because the space between the skull and the brain is smaller, what you see in younger individuals is you see a pretty dramatic change in their mental status because of that bleeding in the brain. Not the same in older adults. In older adults, you may still see this bleeding, and as a matter of fact, you often do, but because there's more room for the blood to accumulate because of that atrophy, you may not see a change in their cognitive status until there is kind of a significant amount of bleeding that has taken place. And that is one of the factors that leads to this increased fatality in older adults, that pooling of the blood that takes place over time and takes place in a large area because of the atrophy in older adults. So we talked about pre-existing health issues, and what I want to touch on here is Another challenge with evaluating individuals after a brain injury and even after a mild brain injury is some of these pre-existing conditions actually have symptoms that mimic a brain injury. There are also significant medical complications that take place after injury in older adults. So you already have a population that may have cardiac and cerebral vascular complications, pre-existing conditions, and then the injury itself can cause exacerbation of these complications or new complications in these areas. So when we look at older adults, we've talked about how you see more disability, higher mortality rates, kind of poorer functional outcomes compared to younger people. So kind of you may think that the picture is a little bit depressing, and it's kind of a mixed picture. Before we move on, I just want to kind of highlight kind of one study that was able to identify some of the factors that kind of point to an increased risk for the worst outcome, which is mortality, following TBI. And this speaks to the fact that for some individuals who have pre-existing conditions, particularly diabetes, because diabetes tends to bring with it a number of other conditions. So for individuals who have diabetes, individuals who have more medications, and individuals who have more respiratory medications, those are the individuals who tend to have the worst outcome following TBI. And many of those factors tend to cluster together. But for individuals who do have TBI, and I see we're getting a little short on time, so I may go kind of a little fast with some of these slides. I'm going to kind of give you the kind of end of the story before we kind of start this. The research shows that when you control for severity of injury, individuals, older individuals who are age 65 plus have as good a functional outcome as younger individuals who have rehabilitation. So the kind of take home from this is that if you are an older individual or if you are working with an older individual who has a TBI, they have the same ability to benefit from rehabilitation as a younger adult. Unfortunately, many of our older adults who have TBIs either go undiagnosed, or if they go diagnosed, they don't tend to get referred to for rehabilitation. And I think one of the reasons for this is if you kind of look at this slide that's on your screen now, the factors and the challenges or impairments that can happen following a TBI can be almost identical to things that happen to individuals in normal aging. So I think many times what happens, especially if there is not a good baseline evaluation or good baseline information about the older individual, what can happen is the sequelae that are noted are attributed to normal aging and not correctly attributed to TBI. So I can't stress enough how important it is to have kind of good information about the individual, to know the patient, and to be able to advocate for the fact that many of these challenges either were not present previous or were not present to the same degree as they're present now. So with older adults, really, if we're talking about falls, and that is the primary mechanism of injury, so we really are talking about falls, the vast majority of falls are not witnessed. The vast majority of falls are not reported. because many of them are minor. Many of them don't even result in a bump on the head, or if they result on kind of a bump on the head, it's kind of judged to be fairly minor or inconsequential and is not reported. Or we have an individual who is sensitive to the fact that if they do report that they fell, maybe some things are going to happen to them that they would rather not happen, so that they don't report it. So you have that. On the milder side, on the more severe side, you may have individuals who, if they suffer a significant fall, they've got significant orthopedic injuries. You've got a broken hip, you've got a broken leg, you've got a broken shoulder or arm. So those orthopedic injuries kind of take the medical attention, and they're neglected to see that this individual also had a fall and a TBI as well. And then, as I mentioned earlier, the fact that these symptoms can happen over time, they don't necessarily appear right away. So it's not the same as you fall and you break your leg, you break your hip, you fall and you have the symptoms of a TBI right away. It may take a little bit of time for the TBI to actually manifest itself. Okay. When we talk about the symptoms of TBI, and we talked about them earlier, but I just want to highlight the symptoms of mild TBI, because in our older population, these are the symptoms that you're most likely to see, being headache, kind of slower processing, fatigue, kind of change in energy and motivation. You're going to see some problem-solving problems. You may see loss of balance. You may see some changes in mood and some changes in sleep, with the emphasis on kind of a change from the individual's prior level of functioning. For more moderate to severe TBI, these injuries tend to be diagnosed. So you're going to see nausea, vomiting, you're going to see loss of coordination, slurred speech. You're going to see much more significant symptoms. So when you kind of think about the symptoms that you want to be aware of, these symptoms are much more likely to come to the attention of a medical professional, whereas I'm going to just kind of go back to the previous slide, where these kind of symptoms of a more mild TBI, or what we may call a concussion, are kind of slower to manifest themselves and less serious. So sometimes they can be overlooked, or they can be misattributed to something else. So when you're thinking about symptoms to be aware of, I would focus and suggest that you focus on these more milder symptoms. Okay. So I've talked about many times a pre-injury baseline. So, if you're working with somebody, have collateral information from their family to be able to know kind of what their baseline was, and don't make assumptions about where they were. When we work in brain injury, the Glasgow-Coma scale tends to be the gold standard in terms of functioning and prediction. Because of the cognitive and physical components of this scale, in an older population, it's not really reliable. So that's why the baseline is really important. Neuroimaging is also important for this population. Remember, I said earlier that these folks are folks who have a kind of slower onset of hemorrhage, so having the neuroimaging is going to be important. And then last, but by no means least, maybe this should be first, is neuropsychological evaluation can really help determine what the effects of a TBI in an older adult are. And in combination with knowing the individual's pre-injury functioning, may be able to delineate specifically what are the changes that can be attributed primarily to the brain injury versus what was this individual capable or not capable of before the brain injury. So when we talk about TBI in older adults, as I mentioned earlier, they certainly can benefit from rehabilitation. But when we kind of look at the rehab process for these folks, we really need to take into consideration each individual, where they are medically, how they're able to tolerate cognitive and physical activities, because rehabilitation can be a pretty intense process. And for older adults who may have a number of medical complications and then have the fatigue that is a consequence of TBI, it may be difficult for them to tolerate rehab. So that's why a subacute rehabilitation setting may be preferable for older adults as opposed to some of the more traditional kind of inpatient intense rehabilitation settings. But it really varies by individual, and they need to be evaluated to determine what kind of rehabilitation they can benefit from. So when we look at rehabilitation, you'll see kind of mobility and balance is at the top. With falls being the greatest risk factor, what you want to do is prevent a second fall, because once an individual has had one fall, they're at a significantly increased risk of having a second fall. And if you're in a hospital, you're at high risk for having a fall. So it's kind of a vicious circle when it comes to falls. So mobility and balance are really stressed when it comes to rehabilitation as a means of secondary balance. And then the primary focus is making sure the individual can be independent in their self-care, in their ADLs and in their IADLs, because what you want to be able to do is preserve the highest level of functioning that you possibly can for the individual and return them to their previous level of functioning. So remember, I started with the outcome first, that older adults can and do benefit from rehabilitation, with the caveat that it does tend to take them a little bit longer to do so. But that should not be a reason that they are not referred for or don't have the ability to benefit from increased rehabilitation. I want to wrap up with a little bit of information about traumatic brain injury and neurodegenerative disorders. There is a significant body of research that shows that for individuals who have moderate to severe TBI earlier in life, they are at increased risk for Alzheimer's disease and Parkinsonian type symptoms, not Parkinson's disease per se, but the symptoms as they get older. What we don't have information for, interestingly enough, is for our older adults. So if you have an older adult, 65 and older, who has a TBI, we really don't have any information about the likelihood or the propensity for them to go on to develop a neurodegenerative disorder. When we look at older adults overall, there really is a lacking of research in this area for older adults and their outcomes. So while we know with younger adults that if you have a moderate to severe brain injury earlier in your life, you're at an increased risk. It doesn't mean that you're going to develop this disease. It just means that you have a higher likelihood than someone who does not have a brain injury. Okay, so I think I already kind of said all of this, but I'll give you kind of a minute to kind of look at that. Okay, so when we talk about brain injury, right now the way and the state of the art and the state of the science is that there really is no cure for brain injury. So when we think about brain injury, we think about prevention. And there have been kind of wonderful campaigns for seatbelt usage and helmet usage when it comes to prevention of brain injury in kind of children and adolescents and young adults. So when we think about our senior population, certainly seatbelt usage is important, and helmet use, should they engage in sports, is important. But really what we're looking at for this group of individuals is how do we prevent falls? And what do we do to prevent falls, because falls are the leading cause of brain injuries in seniors, so that if we can make a difference in the number of individuals who fall, we're going to reduce the number of individuals who have a brain injury. So the ways to do this are exercise is very important. Balance, core strength, coordination are all key factors in being able to prevent falls. Medications should be reviewed very regularly with healthcare providers. It is not unusual for older adults to be on multiple medications, and maybe these multiple medications have interactions that lead to dizziness, that lead to sedation, and that because of those factors lead to falls. So keeping up with what the medications are and what the side effects of the medications are is crucial. And when it comes to medications, less is more. The least amount of medications somebody can be on, the better off they're going to be. Vision should be checked regularly. You know, as individuals age, they have many changes in their vision. There are many visual disorders that manifest themselves in older adults. So having accurate lenses, having accurate glasses, having accurate assistive devices is really important. And then finally, for prevention, looking at the home environment. And I realize this is easier said than done, but looking at what you need to do in the home environment to make it safe, to make it safer for the individual. If it's a cluttered environment, do you need to declutter and make it less likely that the individual is going to trip over something? Is it a situation where they're very attached to their throw rugs? They are a very dangerous thing when it comes to falls. So making sure that if you cannot get rid of the throw rugs, what do you do to tape them down to make sure that they're kind of not something that is going to be tripped over? Where are important items placed? Where's the bedside table? Where's the TV remote? Where are things that they reach for? Because many times it's reaching for something that can cause a fall. Do they have grab bars? Do they have kind of assistive devices to reach for things? Do they have what they need in their environment to be safe and to prevent a fall? So in conclusion, I really want to thank you all for spending some time with me today on this. I want to kind of wrap up with a couple of key points, a couple of key takeaways. So, you know, as we know, our population is aging, and although TBI is a silent epidemic overall, in our older population, it's an even more silent epidemic. And as we have an older population with more brain injuries, it's going to become more of a problem for our health system. So we need to get in front of this. So one way to get in front of it is to advocate for our seniors. Really, after a fall, after a documented fall, an individual should be screened for TBI. And they may need to be screened immediately, and then they may need to be screened a little bit after that. Because remember, sometimes the sequelae do not present themselves right away after a fall. But that screening is key, and knowing their baseline. It's also important for us in the field to advocate for older individuals and to make sure that medical professionals and family members know that older individuals can benefit from TBI rehabilitation, and that we should not attribute all of their symptoms to normal aging, and because of that, say that they don't need rehab. They absolutely can benefit from rehab, and if the symptoms are due to a TBI, we should make sure that they get the rehab. As individuals age, their needs change, their presentation changes, and we need to make sure as caregivers, as medical professionals, as family members that we are really looking out for what their needs are, helping them to stay safe in their environments, helping to reduce falls, helping to reduce motor vehicle accidents. Just because falls are the primary cause and the most common cause doesn't mean that we shouldn't intervene in other areas and make sure that they're safe drivers and so forth. So I really want to thank you for spending some time today. We have just a very few minutes for questions, and I thank you for your attention. Laura?
Oh, thank you, Dr. Boyer. Wonderful information. I have a question here asking if there are any programs in New Jersey for senior fall prevention.
That's a great question. You know, as I mentioned, there are a number of things that individuals can do on their own, but if you remember, the biggest thing they can do is exercise. So there are actually two programs that I'm proud to say the Brain Injury Alliance sponsors. One is a national program called A Matter of Balance, which is what we call an evidence-based program. So there's research to support that this program works, and it helps individuals gain confidence. It helps them know what types of exercises and encourages exercises. And there also is another program, kind of I don't want to say a spin-off from A Matter of Balance, but it kind of is a spin-off from A Matter of Balance. It's not the formal national program, but it kind of takes some of the best parts, and it's called Heads Up for Seniors. And it also kind of teaches balance and so forth. And if you're not kind of in an area where you have access to one of those programs, hopefully you are, but if you're not, look into yoga, look into Tai Chi, look into Pilates. They're all low impact, and they emphasize balance and coordination and strength of the core. So those are all things that are going to help reduce falls.
Dr. Boyer, thank you so much for taking time out of your very busy schedule to present today on this amazing, wonderful topic. For those listening, if you have any further questions, you can email me at the Brain Injury Alliance. My email address is ljacobs, L-J-A-C-O-B-S, @BIANJ.org. This webinar will be placed on our website at www.bianj.org, along with many other informative and interesting topics.